Great. All right, so as Jenny mentioned, I'll be speaking about our upcoming favorable histology Wilms tumor trial, ARN 2231. I should disclose my wife works as a senior medical director for Janssen, but I won't be discussing any of their products today. I also should mention anytime I give a talk on this topic that though I have this role at COG when I'm presenting, it's really more my own opinions. I'm not acting as a COG representative per se. Also, as a disclosure, I like to use dad jokes to break up my talks to keep people engaged. So to start with one of my kids' favorites, did you hear about the mathematician who's afraid of negative numbers? He or she will stop at nothing to avoid them. So the goals for today, I'd like to talk a little bit about what the committee is, who we are, and then review the important surgical issues for 2231, what you'll need to know in terms of helping to take care of kids on study. A special thanks to Jenny for inviting me to be here. I'm very humbled and honored to do so. The Renal Tumor Committee itself is actually a group of almost 70 people from various disciplines that are working together to do research for children, adolescents, young adults with renal tumors. And we busy ourselves with biology, protocol development, clinical trial conduct. And I would add on here that I think we're a resource for our community. And so that's part of what we're here for today, is to talk to you about how we can be a resource for the community as far as how our studies are conducted. I also want to say what we're not. So I think there's a misconception that somehow we're a judicial panel, Oz behind the curtain saying what's right or what's wrong. And essentially outside of the conduct of a specific clinical trial, we don't have a lot to say about how patients are surgically cared for, though I think our guidelines and the protocols get used as clinical guidelines. That's not technically what they're for, and I would refer you in this case to the NCCN Wilms Tumor Guidelines panel. But this is probably the thing I enjoy the most about my job, is being able to work with these 13 other outstanding surgeons and outstanding humans to do this work. And I think we would all be happy to serve as a liaison from our committee to you in the community, that if there are questions about the trial or anything very specific, we would be happy to be there for you. While mentioning those names, I want to say another big thank you to Dr. Ehrlich and Dr. Schamberger, and publicly thank them for all the work they've done on the Renal Tumor Committee over the last almost 25 years. And it's a great privilege for me to stand in their shoes now. But without their work and dedication, we wouldn't be where we are today in this field, without question. So if you see them, thank them. I also want to kind of decode COG studies. People will get up and talk about COG trials, and they'll rattle off a number of letters and numbers, and it can be confusing as to what they mean. So the COG studies generally start with A, and then the next three letters have to do with the disease committee or the discipline that it's coming from. In this case, REN would refer to a renal study, and then the numbers do mean something. The first two are the year that the study was activated, not open, but activated. And then the next number is the phase of study, and the last being the order of that kind of study that year. So in this case, 2231 was activated in 2022. It's a phase 3 study and the first one in that year. It has been approved by COG and CTEP, so we hope for it to be open by the end of the year. I like to say some studies are like speedboats, very direct, get there quickly. This one is more like a cruise ship, meaning it's very large, it's very slow moving, but there is room on it for almost every child that has favorable histology Wilms. And the overarching aim is to risk stratify these kids and then improve outcomes. So that'll mean for some cohorts, we'll de-intensify therapy. For example, we're going to study an expansion of nephrectomy only for some kids, but for some children, we'll intensify therapy, those that have negative tumor biology. But in general, they'll initially be basketed into very low standard, and high-risk groups, and then subsequent patient and tumor characteristics will help decide their ultimate treatment. So coming on to then the key surgical points, we are still prioritizing upfront nephrectomy, though we will have a dedicated pathway for delayed nephrectomy if you feel like that's the best treatment for that individual child. It's important to understand, though, that all of the kids that are undergoing delayed nephrectomy will be local stage 3, and they all have to have a biopsy for us to get that information up front to appropriately risk stratify them. The reasons for delayed nephrectomy has not changed from prior trials. But we are going to really try to standardize biopsy. So while open and image-guided percutaneous approaches to biopsy are options on the study, we really want to try to get the information we need, and so we're going to standardize the way those percutaneous core needle biopsies are done. We're looking for 10 to 12 non-necrotic cores that are 14 to 18 gauge in size and at least a 2 centimeter throw on those. So if your IR colleagues are the ones doing it, we would really want you to be involved from the beginning when they're doing that so they understand the necessity of getting all this information. FNA as the only type of biopsy is strongly discouraged because we just won't get the information we need to put the patient on study. You also must sample lymph nodes to be on the study. There has to be at least one lymph node that's pathologically evaluated. And we'd like to have more than 5, but they won't be on study if you don't have one, whether that's upfront or delayed nephrectomy. And we have some specific aims in the trial looking at the number of lymph nodes sampled, the number positive, and lymph node density. We also want to drill down onto where are these lymph nodes coming from. So we ask you to be rigorous in when you send the lymph nodes to detail where anatomically they're coming from and put these details in your operative note as well. Thanks to Ken Gao for putting together these excellent figures that are now in our surgical guidelines, and they detail where we're hoping for lymph node sampling to come from. So essentially the ipsilateral renal hilum, around the ipsilateral great vessel, and then also the inner caval space. And so this varies obviously slightly from right to left. Also, we want to further some of the work that Dr. Ehrlich has done around formalizing the way we refer to tumor disruption. So I think historically spill and rupture were kind of used interchangeably, but we really want to codify that preoperative rupture, it's a preoperative event as opposed to intraoperative tumor spill, which is during the time of resection. And that tumor biopsy itself is considered a local tumor spill, whether that's open or percutaneous needle biopsy. So essentially it's the timing of when this event happens that helps us to understand if it's rupture or spill. And it's not just language, it really matters then for how radiation is given. So as you probably know, preoperative rupture is the indication for whole abdominal radiation, while a local tumor spill is an indication for flank radiation. But when we at the central review level try to go back and adjudicate, well, was that done appropriately in a quality control manner, essentially the place we look to see if the radiation was given the way that should have been indicated is looking at the op note to see, did the surgeon call this preoperative rupture or intraoperative tumor spill? So please document clearly what you found and what you did. For hepatic metastasis, we'll have a standardized approach now, so we're discouraging a formal anatomic resection at the time initially of nephrectomy, that we're hopeful after 2 to 4 cycles of therapy that we can make the resectability of that easier or obviate the need for the resection. Staying on the theme of metastatic disease, as you may remember from our last trial, those that had isolated lung nodules, if they had a radiographic complete response after the first 2 cycles of therapy, they could be considered rapid complete responders and avoid lung radiation. We're going to try to encourage expanding that to children that after those 2 cycles have a limited disease burden in the lung that could be completely resected. If you can do that and it turns out that those lesions are either all dead or were never tumor to begin with, they can also really be complete responders and not need lung radiation or chemotherapy intensification. Another important surgical issue will be placing a line at the time of the nephrectomy. So we're expanding the nephrectomy-only cohort. So kids up to the age of 4 that have stage 1 disease and no adverse biologic factors won't be getting adjuvant therapy, so wouldn't need a line. So be thoughtful about that. And then a special thank you to Jenny Aldrink, Ken Gao, and Andy Davidoff for putting together our synoptic operative note for the nephrectomy that's being built into Epic that will be available for Epic users, and also through educational efforts we'll make that available through PDFs. And essentially we're just trying to standardize what data gets put into the op note, because that's what we use at a central review standpoint to extract central surgical data for our trials. These are all the diagrams based on the stage and the risk of how patients will be treated on this study. I won't expect you to memorize that. It's very overwhelming. But the reality is in 2024, this is personalized medicine. This is how we identify exactly how much each child needs to get cured. Hopefully no more treatment than they need and no less than they need. So in conclusion, our committee surgeons are here to help. Please reach out. You can help us by using the synoptic op note, by documenting very clearly what you did and what you found in the op note, and reach out to us if you have questions. So to wrap with a dad joke, why did Mozart hate chickens? They were always going on about Bach, Bach, Bach. Thank you. This is my family who I actually work for, and if I can ever be of help in any way, these are all the ways to get in touch with me. Thank you.
Thanks, Nick. I think the Renal Tumor Committee was jealous of the complicated tree that the Neuroblastoma Committee had, and they decided they would one-up it by making it even more complicated. So now we're going to jump into talking about AOST 2031, which is a phase 3 trial from the Bone Tumor Committee. Hopefully you've heard about it before, but I want to give you some important updates about it and encourage participation. I don't have any relevant disclosures for this talk. So metastatic osteosarcoma is a problem. The long-term survival remains 15 to 30%, despite basically us trialing a number of different agents, but still settling on the same MAP chemotherapy that we've been using since the 70s and 80s. But because this is a chemo and radiation-resistant tumor, surgical clearance really is key. And so we try to remove all sites of metastatic disease. And in order to do that, the standard approach through the years has been open thoracotomy with manual palpation of all foci of disease. And the rationale for that has largely arisen from data that shows that compared to the CT, even with modern thin slice CTs, we find additional foci of tumor in 20 to 25% of cases. But despite that, there is no evidence showing that finding and removing those 1 to 2 millimeter nodules, those grains of sand, actually impacts survival compared to the alternative of doing thoracoscopy to remove just the nodules that we know about. In fact, a multi-institutional study by the PSORC group a couple years ago, looking at 200 patients, showed that for those with oligometastatic disease, which we define as 4 or fewer nodules per side, the outcomes between thoracoscopy and thoracotomy, to the best of our knowledge, are similar. So in this context, and with years of sweat and blood by John Doskey and others navigating COG and CTEP, we were able to open this phase 3 randomized controlled trial comparing thoracotomy to thoracoscopy. This is really a very unique study. The vast majority of phase 3 trials in COG are comparing 2 different chemotherapy regimens. So this is one of very few examples where a surgical aim has been the primary focus of a phase 3 study. And the primary aim of this study is to compare thoracic event-free survival in patients with resectable oligometastatic osteosarcoma who are randomized to thoracotomy or thoracoscopy. Secondary aims include event-free survival, overall survival, and pain interference. Although this is a COG study, COG is part of the NCTN, or the Clinical Trials Network, and so this study is open to adult patients in any of these other cooperative groups as well, so please encourage your adult thoracic surgeons. So the eligibility includes patients under age 50 with oligometastatic disease, so 4 or fewer nodules per side, at least one that is 3 millimeters or larger, none that are larger than 3 centimeters. All nodules must be peripheral, they can't be on the chest wall, they must be resectable by wedge resection, not anatomic resection. They must have already undergone successful local control, they can't have extrapulmonary disease. And this is really for patients in 2 different groups. Those who have METs at the time of diagnosis, and those who were initially localized but had a first recurrence in the lung. And they cannot have had prior therapeutic pulmonary surgery. So this is what it looks like to enroll a patient on this study. This is an example most specifically for those who are initial diagnosis. They've already gone through their induction chemotherapy, they've already had their local control surgery, they get that CT scan that is preparing them for their pulmonary surgery. And that's when they go on this 28-day clock from the time of the CT to the time of surgery. They need to be enrolled on the study within 14 days. After that, a central radiologic review occurs, and then there's a couple days available still for getting everything planned for surgery. Because these patients, by definition, have 4 or fewer nodules per side, we do encourage you to do both sides at the same time if they have bilateral disease, but if necessary, and if you choose to space it, you can separate the 2 sides by up to 8 weeks. There's other key features of this study. They're having rapid central radiologic review, which is something new for COG. We're doing patient-reported quality of life studies, which is really going to be very informative. And we're getting a treasure trove of biobanking and biologic correlates, which is going to allow us to better understand this disease and hopefully eventually get some treatment better than MAP. So despite all the excitement around the study, this is where we're at. So the study was activated in February of 2022. We have over 200 sites with the protocol open, which is wonderful. Thank you. but we've only enrolled 22 patients so far. And this is a problem, and this needs to get better if we're gonna, as a surgical community, have this be a successful study. We've tried to listen to the feedback from the community and have enacted a number of amendments to try to encourage enrollment. We've changed some language so that we no longer exclude pleural lesions if they're not on the chest wall. We're allowing for surgery to happen after completion of chemotherapy. We're allowing them to have had prior diagnostic surgery as long as they haven't had therapeutic surgery. And then we've changed some of the time intervals and definitions. But we're always open to understanding the limitations to enrollment and trying to improve the studies so that as many patients as possible can be enrolled. But despite this, it really seems like the primary problem preventing enrollment is a lack of clinical equipoise. And so I'd like to try to make the case here in the last minute that there is equipoise. There are arguments both in favor of thoracotomy and thoracoscopy. Those who argue for thoracotomy say that you identify these occult nodules in 25% of cases. It's easier and more reliable to find the nodules. You can do a smaller wedge resection around the nodule because you don't have to do a big stapled wedge resection. You don't really need to use adjunctive localization techniques. And with modern thoracic ERAS protocols, including muscle-sparing thoracotomy, intercostal nerve cryoablation, and avoidance of chest tube, they really recover quickly. Those who argue for thoracoscopy say that we have reliable localization techniques, we have familiarity with this approach from other tumor types, it's quicker and easy recovery, it's repeatable, and you can wait until that 1 millimeter nodule is 3 millimeters, and there is no evidence of improved survival with thoracotomy. So with that in mind, one more appeal, we really need you to help make this into a successful study. Please communicate with your partners, your oncologists, and your adult thoracic colleagues so that we can get patients enrolled. Thank you.